Welcome to this evening's webinar, Avian Influenza H5N1, Measles and Dengue. Current advice for primary care practitioners. My name is Serena, your RICGP representative for this evening. We are joined by our panelists, Dr. Kerry Chen, Dr. Emily Doi, Kira Glasgow, Dr. Jen Koch, Associate Professor Matthew O'Sullivan, Kathy Dempsey, Professor David Durham, and GP Facilitator Rebecca Hoffman. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders, past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. And here's the learning objectives. Please have a read through and feel free to ask any question at the end. I will now hand it over to Emily to go through our first learning objectives. Thank you.
Good evening, everybody. Thanks for having me. I'm the manager of surveillance engagement in the animal biosecurity team in New South Wales DPI. So I'm here to give you an idea about the ecology of highly pathogenic avian influenza, specifically H5N1 clade 2.3.4.4b, which is not the serotype we're currently dealing with in chicken farms in Victoria. So if we can pop to the first slide, please. So firstly, the global presence of high-path avian influenza. This map shows the geographic presence of HPAI in domestic and wild birds across the globe as at the end of April this year. Australia, as you can see, remains the only continent not to have recorded H5N1. And that was following the recent incursion in Antarctica. So in brown sucus birds in February, this is pretty close to the western tip of Antarctica, is pretty close to South America. And this was not unexpected, given that there'd been lots of detections and several mass mortality events of marine mammals in South America. Next slide, please. So is this the new normal? It is certainly in the animal health field. The traditional scenario for HPAI is that it circulates in wild birds and is endemic in Australia. And when it gets into contact with commercial poultry, it then mutates into a high path variation at the flock level. Then it spreads through farms, within farms and across to other farms through movement of birds, fomites and people. The traditional scenario has been associated with seasonal and temporal trends following natural migratory movements of wild bird populations, given that they represent the natural reservoirs of HAI. The H5N1 variant of concern was first identified in domestic geese in China in 1996. And in the ongoing endemic that's happening around the world, the high path variation is actually maintained in wild bird populations year-round and is transmitted directly into the poultry farms where it's been detected, and also into mammals, in particular seals have been greatly affected. So this is a massive change in the epidemiology of AI. And there's certainly concerns around HPAI becoming endemic in wild bird populations and the implications that that might have on wild birds and mammal populations, also the economics of poultry farming and the impacts on human health. Next slide, please. So how about the evolution of the Australian origin low-path AI viruses? Looking at that, do we think that they can become this other version of HPAI? Low-path AI is endemic in wild waterfowl. About 1.9% has been detected in like a broad Australian surveillance study, but that's potentially higher based on more recent surveillance results. The source of all Australian outbreaks to date, including what's happening in Victoria, has been the old-fashioned low-path to high-path ecology and epidemiology pathway. So that risk is persistently present, and it increases under certain conditions, which are pretty broad. So when it's wet, that's favourable to wild bird breeding and more numbers in the field. And when it's dry, we have potentially more wild birds hanging around where there's poultry farms looking for food and water. So certainly larger commercial flocks offer greater cycling potential of these low path viruses into the higher and then higher risk of evolution into the high path. And then there's an ongoing shift into free range systems, particularly for eggs, but also in meat production. So clearly this increases the exposure risk between wild birds and poultry. The last 2 outbreaks we've had in free range have been in free range flocks in New South Wales, and certainly what's happening at the moment is associated more with free range than housed chickens. Next slide, please. So this is a slide about the movement of birds in our region. So our region is called the Australo-Papuan region, and it's largely self-contained compared to other regions of the world. We've got smaller numbers of species of birds that migrate to the region annually. And the birds that make their migration follow the East Asia, Australasia flyway. They come to Australia between August and November, and usually to breed, and they come from as far north as Alaska and Russia, and they down through eastern parts of Asia. In trying to understand why we've not seen H5N1 yet, there's a few dynamics of the East Asia Australasian flyway that we need to think about. So the migratory birds to Australia are generally shorebirds compared to waterfowl, and we know that shorebirds don't move that far inland in Australia, and they tend to shed the virus at a lower rate than the waterfowl. Also, that great distance of migration potentially means that the shorebirds that are infected with HPAI don't make the journey. We're still not sure about the pathogenicity of the H5 virus in shorebirds compared to waterfowl. It could be that they're just unable to make the distance. We don't really know at this stage. Targeted surveillance is being conducted, and in 2022 and 2023, we still failed to detect any H5N1 in returning migratory birds. There is certainly potential for movement from Antarctica to Australia, but we don't know with much certainty if that's a real idea. We also need to focus our consideration of transmission both on avian species but also marine mammals are becoming increasingly important. Next slide, please. The local wild bird movements, now that's local in our region rather than just constrained to Australia. Wild birds and waterfowl species east of the Wallace Line move locally year-round, but typically don't go west of the line, and that's the solid line in the picture. So that tells us, looking at the map, that presence of HPAI in Indonesia means that the local movements do present a level of risk to Australia. Next slide, please. So this is a bit about what we do in the animal health space to do with targeted AI surveillance. So we have a national active surveillance system for AI and wild birds in Australia, and it's called the National AI Wild Bird Surveillance Program. Under the program, the surveillance focuses on sampling feces from waterfowl for PCR testing at sites where we know there's mixing of waterfowl and shorebirds, and where it is in proximity to poultry, high poultry densities, as well as humans. In New South Wales, this has recently been expanded, and now it covers the Hunter Valley, Riverina, and Northern Tablelands. Next slide, please. Oh, we've missed. We can go back a slide. Just about passive surveillance in New South Wales, that also occurs all the time in both domestic and wild birds by way of submissions to the state animal health lab called EMAI, and that's usually done by private and government vets. Anything with more than 5 mortalities, we push to exclude AI from diagnostics. And during the migratory bird arrivals, we're doing huge numbers of those exclusions. We also have other national management plans to do with Newcastle disease, which is another chicken disease that captures another lot of passive surveillance for AI at the same time. So we're continuing to push for more and more exclusion testing so we have more increased chance of detecting it if and when it does arrive. Thank you. That's it.
Thanks, Emily. We'll now hand it to Kira for her part. Thanks.
Thanks, Emily. So I'm Kira Glasgow. I'm Director of the One Health branch, and we work closely with Department of Primary Industries to address various risks from zoonotic diseases, of which avian influenza is one that's been in the news recently. And this section is just going to very briefly cover the advice to patients at higher risk of exposure to avian influenza. Next slide. So at present, the World Health Organization has assessed the risk to people exposed to avian influenza H5N1 as low. There has been no reported human-to-human transmission of H5N1 viruses since 2007. And of course, this situation requires ongoing close monitoring, which Health Protection New South Wales, which is where I work, is actively involved in. We do know that avian influenza is likely to be detected by conventional influenza assays, which Jen Koch will be talking about soon after me. And there are specific things that we can advise in order to ensure that the avian influenza tests are appropriately conducted where clinically indicated. For those people who are engaged in higher risk activities, for those with exposure to infected birds or animals or contaminated environments, the risk does increase slightly, but only from low to moderate. And that includes particularly in countries overseas where the virus is already circulating. Patients who partake in high-risk activities should be taking additional precautions to prevent infections. So this includes things like wearing PPE and avoiding high-risk environments. So travelers to countries where avian influenza is circulating should be taking particular care to avoid those high-risk environments. And people who work with poultry or who care for sick and injured birds are also a population who are considered at higher risk. Next slide. So people who are traveling overseas, we do know that this particular strain that Emily has mentioned is moving quite quickly and is now on every continent around the globe. And we do know that the surveillance for this particular virus is only as good as the investment in those surveillance systems. So our advice is that anyone who's traveling to any affected country and has had contact with infected animals or environments, or is planning to have contact with infected animals or environments, may be at greater risk of exposure. And this particularly includes people who might be going to places where they will have more of that very direct contact with poultry. So particularly in rural villages or staying with family and friends where poultry is kept indoors. Now, we don't have the virus, this H5N1 virus in Australia yet, but it is routine practice that we recommend that people who work in the poultry sector do get their seasonal influenza vaccine. And this is because, as Emily mentioned, we do actually have low pathogenic avian influenza circulating in Australia, endemic in our wild waterfowl. So people who are in direct contact with unwell birds, which includes poultry sector workers, wildlife rehabilitators, vets, and lab workers, are more likely to be exposed to various types of avian influenza viruses. Next slide. We do have a few other considerations that people in primary care may be exposed to. There's, of course, the mental health concerns for people working in the poultry sector. And there's also concerns that we've been seeing in the media about food safety and nutrition. There's been some news about eggs that there's limited numbers of cartons that can be purchased through certain supermarkets at the moment. And of course, these things are going to be raising anxiety in patients and consumers. Next slide. So we have a series of fact sheets that are now available online that outline the public advice, mainly around avoiding contact with sick and dead animals, how to report if you see sick and dead animals, how to follow good safety and hygiene. And for those people who are at higher risk of exposure to avian influenza, what they can be doing now to protect themselves. And that includes getting the flu vaccine now, maintaining strict biosecurity practices, wearing PPE, and performing very good hand washing as we'd normally recommend during the winter respiratory season. think next slide is just an example of what those look like, and you can find those on our website. And I think that is the end of my section.
Thank you, Kira. Next, pass it to Dr. Jen.
Yes, thanks very much, Serena. Good evening, everyone. My name is Jen Koch. I'm a medical virologist at ICPM at Westmead Hospital. Next slide, please. So in terms of avian influenza testing, samples should be collected using appropriate PPE, and ideally this should be with an N95 mask rather than a surgical mask. This will be discussed later in the webinar. Samples should be collected as soon as possible post-symptom onset. Generally, influenza A virus RNA will be detectable by PCR for approximately 5 to 6 days from the upper respiratory tract after symptom onset. There may be a role for asymptomatic or pre-symptomatic testing in some circumstances. The majority of samples that are collected will be respiratory tract samples, particularly those from the upper respiratory tract, such as nose and throat swabs, nasopharyngeal swabs, and nasopharyngeal aspirates. Lower respiratory tract samples, such as sputum, bronchoalveolar lavages, and pleural aspirates can also be collected for testing. Clinicians and pathology collectors should be very familiar with the swabs and transport media used, as these are similar to what is used for SARS-CoV-2 testing. There may be instances where there is discordant detection of influenza virus from the upper and lower respiratory tract, with detection in the lower tract, but not the upper tract. Request influenza PCR testing or your commonly used audible for influenza PCR testing, such as respiratory virus PCR or respiratory pathogen PCR. Would also be important to provide relevant risk factors, such as international travel, contact with birds or sick animals, as Kira has mentioned, on the request form. It's also important to consider testing of other respiratory pathogens depending on the setting. So for example, looking for other respiratory pathogens that cause a respiratory tract infection in the community, or bacterial complications and co-infections in unwell patients. As conjunctivitis may be part of or the only symptom of avian influenza, conjunctival swabs may also be collected for testing. These are tested using the same swabs per respiratory tract testing. Sera can also be collected for subtype specific testing. This is often not necessary for the acute diagnosis of avian influenza, but does have a role in retrospective diagnoses and also serosurveys. The acute diagnosis of influenza by serology requires both acute and convalescent sera. Avian influenza virus has also been detected from stool and rectal swabs in patients with gastrointestinal symptoms, but this is not a common sample type for the laboratory. And once collected, samples should be transported to the laboratory as soon as possible at room temperature. Of note, samples such as swabs placed in transport media generally remain viable at room temperatures for up to 5 days. Avian influenza is classified as a security sensitive biological agent, or SSBA. For those that are not aware, SSBAs are those that can cause significant harm to human health and the environment if they are deliberately released. There are specific requirements per the SSBA standards that need to be followed with regards to the handling, storage, transport, and also disposal of the biological agent once confirmed. Next slide, please. The target of many influenza PCR assays is the matrix gene, and this is conserved between human and avian influenza viruses, meaning that laboratory assays used for the detection of human influenza viruses should also detect avian influenza virus. But it would be important to confirm this with your local testing laboratory or microbiologist. Note that acceptable sample types may vary with the different assays, particularly for conjunctival swabs, stool, and rectal swabs. Some commercial assays, such as the rapid test, may not list lower respiratory tract samples as acceptable sample types, let alone the non-respiratory tract ones. Some commercial PCR assays have subtyping capacity for human influenza viruses, meaning that they can provide information on whether the virus detected is H1 or H3, but these assays do not have avian influenza targets in them. Although rapid antigen tests may detect influenza virus, these have inferior analytical sensitivity and are not recommended for testing of avian flu. Furthermore, RAT testing does not provide information on influenza subtypes. Now, confirmation of avian flu is done by the 3 WHO national influenza centers that you can see in the slide, and also the WHO Collaborating Center for Research and, for reference and research on influenza. In New South Wales, the national influencer is ICPMR at Westmead, and these national influenza centres regularly participate in WHO quality assurance programs, so the quality of the results is assured. At ICPMR, testing is offered daily and can also be done out of hours if required. In addition, ICPMR also houses the only highest level biocontainment laboratory in New South Wales, where SSBAs are handled. The National Influenza Centres are also able to offer specialised testing beyond PCR testing. At ICPMR, we also have whole genome sequencing that can be used for cluster analysis, contact tracing, and also antiviral resistance, and also virus culture. Two final points to stress. Firstly, the importance of requesting influenza subtyping if influenza A is confirmed in your patients with the relevant risk factors for avian influenza as discussed previously, namely travel or contact with birds or sick animals. And secondly, repeat testing if clinical suspicion for avian influenza is high and the initial test returns a negative result. Thank you.
Thank you, Jan. Now pass it on to Matthew.
Yes, thank you very much. I'm going to speak about the management of suspected cases. The next slide, please. So when to suspect a human case of avian influenza really depends on where we are in the stage of emergence of avian influenza around the world. So next, please. So if you think about where we are now, where we have H5N1 in birds and animals overseas, but not yet in Australia. Next. If you have someone who's had recent overseas travel and significant exposure to birds or animals, next, and they're flu A positive, then that's currently where we'd expect, where we'd want to rule out avian influenza. But if we have emergence, next please, where we do have H5N1 in birds or animals in Australia, then obviously recent significant exposure to birds or animals in the affected areas in Australia would be the trigger to check someone who's got flu A positive result to see whether they have avian influenza. The next phase, thanks, would be if we identify sustained human-to-human transmission overseas. So then if we are seeing human-to-human transmission, which isn't currently occurring, but that's the fear that could emerge, then even just overseas travel to affected areas would be enough to suspect avian influenza in someone who's flu A positive. And of course, the worst case scenario, next please, is if we have sustained human-to-human transmission in Australia. So then essentially anybody who is flu A positive, we'd need to rule out avian influenza. Next slide, thanks. So just in terms of what we regard as a significant exposure to birds or sick animals for the purposes of suspecting avian influenza, it really is that sort of direct contact and direct handling of birds or dead animals, defeathering, butchering, or eating particularly undercooked meat from birds or other affected animals, but also exposure to environments where there's heavy contamination of feces. So they're the sort of questions we would be asking to determine a significant exposure to sick birds or animals in endemic areas. Next, thanks. So in terms of clinical presentations, so it may be typical influenza-like presentations, but it can also be atypical. And we know that many of the cases that have been reported have actually been asymptomatic or quite mild, and symptoms like conjunctivitis have been definitely reported. But you can get very severe disease with H5N1 influenza, and there's certainly been a number of deaths reported. We are also concerned that there may be atypical presentations. We know that in some mammals, particularly cats, there is actually neurological disease that occurs that predominates, and actually not much respiratory disease. And it could be that if it emerges in humans, that may be a feature. So we have to keep cast a wide net. So next, thanks. So in terms of how to respond to a suspected case in primary care, so currently, as we said, we're in this phase where we have H5N1 in birds and animals overseas. Next, thanks. And then if we have a patient with respiratory symptoms or conjunctivitis, next. And they've had recent overseas travel with that significant exposure to birds or sick animals. Next, thanks. Then first thing is we'd want to employ some infection control precautions. So staff within the practice should, who are having exposure to the individual, should be wearing masks and eye protection. Next, thanks. And we'd want to test them for, as Jen said, respiratory virus PCR, but it's important to put the clinical details on the request form, the travel history and the exposure history, and that you may suspect avian influenza. Next, thanks. If that patient then is flu A positive, then they meet the suspected case definition for avian influenza by virtue of those exposures. Next, thanks. And we would want to notify public health and ensure the lab refers the sample for flu A subtyping to ICPMR, and the public health unit can help facilitate that. Next, thanks. In terms of what we do with the patient then, the concern is the mortality rate and transmissibility are unknown when we have a human case of avian influenza, and it may be high and it may be transmissible to others. And so that's why we're concerned about every case that occurs in humans, and I'll talk a bit more about that. But the infection control precautions are important. Next, please. If it's a mild case, it may well be reasonable for them to be managed at home under strict home isolation. Next, thanks. But if they do require hospital admission, the recommendation is that ideally they'll be treated at the biocontainment centre at Westmead, which is a high-level isolation unit that we have for high-consequence infectious diseases because of the concern about potential high mortality and human-to-human transmission. Next, thanks. And of course, notifying public health in either eventuality so that contact tracing and so on can be undertaken. Next, thanks. So why is there concern for human health? First of all, the potential high mortality rates. We do know historically that of all the humans that have been known to be infected with H5N1, the mortality rate has been over 50%. And that's the number that you can see there since 2003. And similarly for other avian influenza strains, that compares to seasonal influenza where it's well under 1%. So about 100 times higher mortality associated with avian influenza infection in humans. Next, thanks. For this particular 2344B influenza clade that's circulating at the moment, there certainly has been severe disease and deaths, but equally there has been asymptomatic and mildly symptomatic cases. So essentially when a strain emerges and if there is human-to-human transmission, we're not going to know initially exactly what the mortality rate is. And so we're going to have to assume the worst case scenario. Next, thanks. What about transmission from person to person? Well, usually avian influenza strains are not particularly transmissible from person to person because they're adapted to replicate and spread between birds. And it's to do with the particular receptors that are used within the infected host, the sialic acids, which are in the respiratory tract and differ in humans compared to animals. Next, thanks. But the concern is you can get mutations in the hemagglutinin gene, which can actually confer different receptor specificity, and then you can get this adaptation so that you do have efficient replication in humans and human-to-human spread. You can also get mutations in the polymerase gene, which can reflect mammalian adaptation and the potential for spread between mammals. Next, thanks. So this can happen, this adaptation within the host can happen either because the virus encounters a human virus and you get recombination between the avian virus and the human virus that confers the genes that allow efficient human replication, or else you can get point mutations in these genes. Next, thanks. And we do know that of human cases of avian influenza that have been described with this clade, there's at least one example where mutations associated with mammalian adaptation and more efficient replication in humans were identified. And so that's a major concern and why every human case of avian influenza has to be taken seriously in case that host and mammalian adaptation is occurring. Next, thanks. Just lastly, in terms of antiviral treatment, it is thought that avian influenza, well, we know that the current strains are susceptible to standard anti-influenza therapies. Next, thanks. So the mainstay of these are the neuraminidase inhibitors, so oseltamivir or Tamiflu that we're familiar with. at the standard dose for treatment is what would be recommended in a case of avian influenza. There are other neuraminidase inhibitors which can also be given intravenously, but the oral treatment has very good bioavailability even in critically unwell patients. Next, thanks. And there is another available antiviral called baloxavir. And if we did have a resistant strain that was resistant to oseltamivir, then baloxavir may come in handy for that. Next, thanks. We can also use oseltamivir for post-exposure prophylaxis in the same way that it's used in post-exposure prophylaxis for seasonal influenza, except we do use a different dose. So we would use it at twice daily for 5 days rather than once a day for 10 days, which is what the usual dose is. Next, thanks. And now I'll hand over to Kathy Dempsey, who will be talking about infection control. Thank you.
Thanks, Matt. So next slide, please. So obviously I'm looking at some of the management for acute respiratory infections, noting that if we had a suspected or confirmed avian influenza, as Matthew's already mentioned, we would implement high consequence infectious diseases PPE. The challenge in general practice and primary acute care is really knowing what that might look like. So going into winter, we currently have a number of acute respiratory viruses circulating. So it's really important that we have some standard approaches to our acute respiratory infection management. So early identification is very important, and working with Department of Primary Industries and obviously public health to keep abreast of what's happening in animal health, but also then anything that's sort of coming into our EDs as well. It's looking at the environmental control that you have in your practice or where you're delivering care. That can include things like air quality, direction of air, and certainly some air exchange as well, or just looking at the environments where you might be seeing patients and clients with acute respiratory infections. Personal protective equipment, and I've go through the next slide with what that potentially looks like. So, you know, basically it is either a surgical mask or a P2N95. There's no question a respirator will provide you with additional and superior protection. The question is, at what point do you need one or the other? And it really depends on the risk assessment that you apply. You will get between 50 and 70% protection with a surgical mask. If you also implement surgical masks as part of your source control, then it limits the amount of emission of circulating virus into the environment as well. So you'll get added control if all parties, for example, are wearing. It's also important to remember to add protective eyewear to protect your mucous membranes. If I can just go back to the slide before, also looking at obviously the appropriate testing, antiviral treatment, looking at patient investigations, monitoring those exposed, or just looking at those exposed. Certainly in healthcare, we have a process to make sure that we look at those that are exposed and manage those equally. Environmental cleaning still forms an important role, particularly with other sort of acute respiratory infections. Hand hygiene remains important, and cleaning of shared equipment. Next slide. We'll skip that one. So we've gone through PPE. It's really important that it's that neck up PPE that is primarily important. The addition of gowns, gloves, it really depends on the nature and the interventions or procedures that you might be, for example, carrying out. So some of the things that you'd be looking at is really looking at what kind of processes can you offer to prevent spread within your practice and with the care that you provide. So it's around masks being available in waiting areas, so you've got source control. Patients with acute respiratory infections ideally should be wearing a mask. Obviously, suspected or confirmed COVID's airborne precautions, which is P2N95s, and health workers to wear surgical masks or P2N95, respirator and eye protection based on risk assessment. So it's really, rather than calling it droplet versus airborne, although we know these viruses do spread slightly different to those that we commonly refer to as airborne, such as measles, we're still looking at respiratory level protection. Next slide, please. Really, this is just to provide you with a narrative around healthcare. So healthcare is currently looking at adding infection control frameworks with respiratory and COVID safe healthcare, so doing local risk assessments and local enhancements to infection control based on what they're seeing in their own local epi. These are some of the things that you can also apply to your own practices, looking at things that you might want to implement and whether or not, depending on what's coming through your door, as to some of the enhanced infection control that you may want to implement. Next slide. And really just there are numerous resources that are available to you. Your own college has some really good infection control guidelines. There's the national, the Australian guidelines on infection prevention and control. There are a number of New South Wales government resources on the acute respiratory infections that you all have access to. And really just finally, the Clinical Excellence Commission, next slide, has additional resources. So the things that we do each year to help the health system is add to our existing suite of resources around acute respiratory infection management and add some winner strategy resources. So there's some of the things that you might want to look at locally, but these are all equally available. You have access to those. We have a number of education and training and video sessions that are available online as well that you can either adapt or implement or manipulate to apply to your own practice. And then I'm going to hand over, thank you, to Professor Durham.
Thank you so much, Kathy. And it's fantastic to be able to join you from beautiful Lake Macquarie in a Wabakal country this evening. I am the public health physician, but also chair the Regional Verification Commission for measles and rubella in the Western Pacific. And it is rather strange that measles is on this rather exotic menu this evening, an ancient virus dating back to at least the 9th century, although it obviously didn't occur in Australia until after 1850. Big shout out to primary care. It's the 50th year this year, and celebrated last month, of the EPI, the Expanded Program on Immunisation. And largely primary care has delivered most of the vaccines that have actually saved the 94 million lives that would have been caused by measles over the last 50 years. So well done to you. Next slide, please. So this is the current global epi curve. This is what's happening with measles. It's amazing what COVID's done to our memories. 2019 was a horror year, and the entire world was sitting in bated breath, wondering whether measles was going to be declared as a FEIC, a public health emergency of international concern. But what worries me, and I've seen the most recent month's data, it'll be published tonight, there's about a 20%, that last little lift up, the 2024 data, is about a 20 to 25% increase in the reported cases on that already. And it's looking ominously like what was happening in 2018 before the big 2019 surge. And we know that global coverage with this first dose or the single dose of measles vaccine dropped by 3% during the pandemic. So there are many more susceptible people out there. So we really have to prepare ourselves that this is likely to become another very large global resurgence. Next slide, please. And if you have a look at where a lot of the activity has been, obviously the very dark blue, and the rates are shaded appropriately, is in Africa and some parts of Europe, particularly Russia and the Ukraine, unsurprisingly, and many of the stans. But you can't actually, if you look very closely at the map, many areas that Aussies travel to and visit their families or holiday and then come back are heavily impacted at the moment, in particular in our close neighborhood, Indonesia, the Philippines, Vietnam, and particularly Malaysia is currently experiencing a large outbreak of measles as well. Thailand and India are also experiencing large numbers of cases. So those are frequent destinations for Australians. Next slide, please. So this is the recent epi of measles in New South Wales. And 2014 is important because that was the year that we were verified, the whole of Australia, to have actually interrupted the endemic transmission of measles virus, which is fantastic. So we are free of wild virus except through importations. All those red bars that you see there are imported cases. Now, clearly that disappeared in 2021 because our borders were closed. So that's a very effective way of preventing measles importations, but clearly not sustainable. But you can learn a lot from this epi curve. Most years, the number of imported cases is more than the blue number, the blue bar, the blue part of the bar. And that's really signifying that because we've got such high immunity coverage, there's very little spread in general on average in our population. There's a buffer of protection because of high herd immunity is the technical term. And on average, we have very few outbreaks which go on to the third generation. So most of them normally burn out because of fantastic high coverage, which is achieved through primary care and also a rapid public health response. The second thing you can see on that slide, at the very bottom of the 2016, 17, and 2020, you'll see there's a little grey line, largely single cases of unknown source. And this is really shows the thoroughness of the public health response in Australia using both epidemiological tools and genetic tools to track the source of the virus. So we do that very well. We are not missing virus. Unfortunately, obviously, with the borders opening up, we're now seeing recurrence, introductions of the virus in Australia. So what's happened in this current year? Next slide, please. So this is our current year in New South Wales. So the 1st of June, we've had 16 confirmed measles cases. A very important thing to reflect on is, and this is what measles is a wonderful teacher. It is that infectious, it always finds gaps in our immunity. So if we look at the cases, they can tell us a lot about who else is at risk and where we need to target our efforts. If you have a look at this, the cases, they're very young, and a number of them have either travelled or they are families of travellers. You'll see that, unsurprisingly, 12 of the 16 cases were unvaccinated. That's not surprising. Sadly, there's still people in our community, about 3% of our community, and in some areas higher than that, that are unvaccinated, and they are at sitting ducks when it comes to measles introductions. Unsurprisingly, a single case had actually had 2 doses of vaccine. That does happen. We expect somewhere between 5 breakthrough in up to 5% of people in populations that are post-elimination. Let's go to the next slide, which is actually quite helpful as well. If you have a look at this slide, you can see that the countries that we're getting measles from are those that are experiencing outbreaks. So that's not surprising. And 6 of the cases, and this is, again, the value of GPs thinking about measles, alerting the public health units, and us putting measures in place to isolate contacts, that most of our cases, secondary cases, were known contacts, and they were in isolation. So they were not placing the next generation potentially at risk. And this is the value of alert general practice, thinking about measles, thinking about fever in return travellers, and saying, I've got to exclude measles in these cases. Next slide, please. We've had 3 clusters, and they're interesting in their own rights. They unsurprisingly have a look at cluster 3. If kids are unvaccinated and exposed to measles in a close household-like setting, they're going to get measles. I mean, that's the nature of measles. Because a high reproduction number, it will actually infect people. But the most amazing thing about the clusters is actually what didn't happen. The 6 of the imported cases, there were no secondary cases whatsoever, despite very careful public health follow-up. And that is really, again, the importance of an early alert to the public health system, but also even more so the importance of background vaccination. High coverage snuffs out measles. It doesn't spread in those environments. Next slide, please. This basically shows us where the cases have occurred. And basically what the slide is telling us is they could occur anywhere. So anywhere that anybody travels overseas to a place that's affected by measles, whether you're on the border of New South Wales with Queensland, or you're on the border of New South Wales with Victoria, or if you're in the big hub in Sydney or anywhere in between, travellers could bring measles back, particularly unvaccinated travellers. And often it is people who are travelling, either young adults, not fully vaccinated. Good idea to check before they travel overseas. Or it's people taking their children back, people who've been born overseas, living in Australia now, Australian residents taking their children back to show off to the family, and they bring measles back. And you can see in the Sydney, once measles is in an environment, because we move, we take the virus with us, which is why it's so important to isolate people early. Next slide, please. We've got fantastic coverage in New South Wales with 2 doses of measles vaccine in most areas. So if you have a look at that slide, the first slide, the dark blue is really where you're achieving over 95%, and the slightly lighter blue is over 93%. And really that is most of New South Wales, but you'll see pockets in the Blue Mountain, pockets up on the North Coast, some pockets in Sydney where there are areas of lower coverage. We can't be complacent at all. Next slide, please. Just quickly, the very important issue of the 6-month dose. So this was an evidence review done by WHO in 2017. Outstanding. You can download it from the web. Next slide, please. And what it looked at was vaccine effectiveness. And people often say, well, why don't we vaccinate earlier? The problem is if you vaccinate at 6 months of age, both the child's immune system and potentially interference from mum's antibodies actually interfere with the child raising a good immune response. And it's often only 50 to 60% of kids that actually produce a good immune response to a first dose of measles vaccine at that age. So that's not the best time to vaccinate. The best time to vaccinate is at 12 months of age with a second dose at 18 months of age, which is what Australia does. However, in outbreak situations, either a local outbreak or where children are traveling overseas into countries with measles outbreaks, that vaccine dose, which is a supplementary dose, doesn't count as dose 1 or 2, should be given. It's going to protect the child against potentially a life-threatening disease. Next slide, please. So just to bring your attention to the 5th bullet there, we strongly recommend, the evidence is compelling, that it's safe and a sensible thing to vaccinate a child between 6 and 12 months of age with an extra dose, a 0 dose or supplementary dose. It doesn't replace the normal dose 1 and 2. They should still occur, but you could actually prevent that child basically developing life-threatening measles infection. Next slide, please. So this is really the role of general practitioners, and I've emphasized it throughout. One is a high level of suspicion. Any febrile illness in a return traveler, ask about a travel history. Cough, a fever, and a rash is measles until proven. Otherwise, if the person has a travel history or an epi that is suggestive, really important to isolate them, notify the public health unit on suspicion, and collect the test. The lovely thing is by actually sending off for PCR on urine sample, first pass, or throat swab, you don't have to always draw blood. The serology can be helpful, but for little children, we know the parents get very upset by it. And then very, very important, keep vaccinating. You guys are doing a fantastic job keeping the children and community safe by vaccinating. And for kids traveling overseas during this high-risk period, children from 6 to 12 months, a 0 dose as well. The last slide is simply a resource which gives a whole lot more depth, which we collaborated with Nikki Turner in New Zealand to recently prepare for the RACP pediatrics group. Thanks very much.
Thanks, David. I will now hand it back to Kira again.
Thank you. And look, mine's just going to be a super quick last slide as we do this round the world trip on around public health risks. It would be remiss of us not to mention the situation of dengue. So the WHO has declared a global high risk for dengue, not only indicating that it is increasing in severity in areas where it is endemic, but it is also spreading to new areas. So we do want to highlight this concern because their prevention measures are actually quite simple. So far this year in New South Wales, we have seen an increase. We're about 1.5 times higher than what we would normally see at the same time of year on average. Most of the people in New South Wales who are returning from overseas with dengue have been travelling to very popular tourist destinations like Indonesia, particularly going to Bali, but also followed by Thailand. Next slide. So we're just asking general practitioners to please refresh yourselves about the symptoms of dengue, what you might see if you have a patient returning from overseas. And if you are seeing patients before they go overseas and you're thinking about measles vaccine and you're thinking about other risk factors, please also use that opportunity to advise them about mosquito-borne infections. So for dengue in particular, where we're seeing an increased risk, or even for women of childbearing age who might be going to places with Zika is potentially a problem. Make sure that they're using insect repellent, wearing long sleeves, using bed nets to prevent mosquito bites, and always doing something to make sure that they're not outside at those times of sunrise and sunset when some of these mosquitoes are more likely to be biting. There is, of course, a vaccine that is available, and we have had quite a few inquiries from people who've seen the news about dengue, but of course, it's not the simplest vaccine to give, so please make sure you refer to the Australian Immunisation Handbook for those recommendations. I'll hand over to Kerry for the last bit about around the world.
Okay, next slide. Look, I just briefly wanted to touch on the fact that BCG vaccination is also recommended for children younger than 5 years of age who are travelling for 4 weeks or more to a country or countries with a high incidence of TB, ideally administered 3 months before travel. There's a website there on our web link which you can make bookings. The BCG vaccine is in short supply, and so it's really only available through our clinics or a limited number of travel health clinics. Also, just to alert you that this is the time of the year where there's a lot of travel to the Northern Hemisphere. We have seen recent introductions of Mpox into Australia with some local transmission in Victoria and Queensland. So we are recommending, again, reminding you that Mpox could present in your practice. We're also encouraging vaccination of those sexually active gay and bisexual men and their sexual partners, and sex workers are recommended for vaccination. That's available through their sexual health clinics. And a number of people may well have had one dose when we had a while ago, and so again checking that they've had the 2 doses to complete the course. I'll stop there.
Thanks, Kerry. We'll now pass it on to Beck if you would like to go through the Q&A session. Thank you.
Great. Thank you so much. I think I'll start at the back and work my way forward. Some of them have been answered online, but I think we will just touch base on a few of them again. So the first question being in regards to the measles vaccination, if the preference would be to give an additional dose 0 or a dose 1 and 2 if requiring, say, at 11.5 or 11 months, just immediately before the routine 12-month vaccination.
Yeah, look, there's really no harm in going ahead, giving the dose 0. You want to get that in before the child travels. You can give the routine dose 4 weeks later, and that would be our strong recommendation.
And what about if they're travelling at, say, that 13, 14-month mark? Is there benefit for giving a dose 0, or what would be an additional dose in that time frame before they travelled?
Yeah, look at the supplementary dose. I think the key thing is the closer you're getting to the 12 months, if you've given a dose already at 12 months, there really isn't value in giving another dose before the 18 months. So the vast majority of children, more than 95%, will be protected by that first dose from the Australian data. So probably worthwhile just waiting to the 18-month time slot.
Great. Thank you. And then I might ask a question of Matt, just in regards to avian influenza and flu-like symptoms when traveling. Lots and lots of people traveling at the moment and returning with flu-like symptoms. Most of those would have been picked up from their plane travel or from the airport. Just really narrowing down, what is it that the GPs specifically need to ask for or ask about? And it really is coming down to the contact with wild birds and the location they've travelled. Are there any other key takeaway messages that you were hoping that we'd be taking away about this?
Yeah, so that significant exposure to the to birds or sick animals. So yeah, like I said, you really want that. They've basically been touching the animal, handling animals, or their bodies, or areas which are heavily contaminated with the feces of the birds. That's really the key you're looking for. In terms of where, I think it's actually, given that it's pretty much everywhere except Australia, I don't think I get too hung up on where in the world they've done that activity, just that they've done it outside Australia. But yes, you're quite right in that there's lots and lots of people with flu-like symptoms who have recently travelled. So we do need something to screen out all of those to perform subtyping on. But that's what we should focus on, that significant exposure to the birds or sick animals.
So everyone's adding more questions about chickens and bird life to their returned traveller history when they come in with flu-like symptoms. And with that, because there are such a large number, at which point are you then wanting us to get in contact with public health and going, this is someone who has been in contact with wildlife and they are presenting with flu-like symptoms, and I'm sending off a respiratory swab. When do we jump on the phone and make that next call?
Well, certainly once you get the flu A positive result, I'd be calling straight away, because, as I pointed out, that actually meets the public health definition of a suspected case once or probable case once you have that flu A positive result and that exposure history. I think if it's a very typical case of influenza and there's a very high risk exposure, you could think about perhaps doing that beforehand. But given how quick flu A results tend to be at most labs because of the introduction in the response to COVID of respiratory virus multiplex testing, we should have a flu A result fairly quickly. So it'd generally be fairly reasonable to wait until you have that result, as things stand at the moment. But of course that might change if we start getting human-to-human spread, or we start getting more the emergence of H5N1 in Australia.
Right. And a question just in regards to the dengue vaccine that's come through. So if people have already had dengue previously but need to travel for Indonesia for prolonged periods of time, mostly for work or to see family, at what point would you consider them to have a vaccination?
Yeah, thanks, Rebecca. Look, the ATAGI advice is that the people who are going to be considered for the vaccine should reside in a highly dengue endemic region for an extended period, and only if the benefits are deemed to outweigh the risks. We do know that people who are given the vaccine, if they haven't had dengue in the past, they can have quite severe reactions if they get a subsequent dengue infection. So there really does need to be a risk assessment approach before considering vaccination.
Wonderful, thank you. I wanted to say a big thank you to everyone on the panel. It was a very large panel and we sped through spectacularly well. And I'm just going to hand over to the support staff for some final wrap up.
Thank you, Rebecca. I'd like to extend my thanks to Carrie, Emily, Kara, Jen, Matthew, Kathy, David, and Rebecca for presenting this evening, and also everyone who joined us online. We hope you enjoyed the session and you also enjoyed the rest of your evening.